As many people know, the Journal of Orthopedic Experience Innovation has been in publication for approximately 2 years. I want to personally thank the authors, Sean McMcmillan, Robert Arciero, and Elizabeth Ford for a really rock star article. Got, I think, over 1,000 views. To get put in perspective, I think a lot of people don't understand that the average orthopedic journal article gets between 55 and 70 views. And I showed this to someone today, and of our 150 articles, we had to go to article number 70 to get to 300. So this article got over 1,000 views, and it's very exciting technology, big innovation, and we thought it was worthwhile to have a journal club related to that. I want to explain to everyone tonight's journal club is recorded. Of course, we're going to put this on YouTube, and we also put this eventually on Spotify for a just in case you have nothing left to do in life and you're driving into work, you want to listen to this on a podcast. We also have a podcast as well. So first off, I'd like to introduce, we have 2 of our 3 authors tonight, which is great. I'd like to introduce Sean McMcmillan. Sean, maybe you could introduce yourself to everybody.
Yeah, so it's good to see so many familiar faces on this call. I'm Sean McMcmillan. I'm an orthopedic sports medicine surgeon. I work for Virtua Health Systems down in South Jersey, right outside of Philadelphia in the Cherry Hill area. I actually had the opportunity to get involved with BioBrace and BioRes probably around 3.5, 4 years ago, or early on. And it was, again, at that point, something that was novel and I don't want to say a dream, but certainly something new. And then, watching the company sort of grow and the product come forward, it's been kind of really nice. And we can talk a little bit later on about, I guess, our own personal journeys with biologic augmentation.
All right. And Liz, I know you're a PGY 2 now, which makes you a hell of a lot smarter than the rest of us on this call. You actually could pass your boards at this point in time. But tell us a little bit about yourself.
Like you said, I'm Liz Ford. I'm a PGY2 at Inspira Health Network, which is in South Jersey. And I kind of got involved with research and Dr. McMcmillan spanning way back while I was in medical school, and have kind of just continued that journey, which has brought us to tonight and BioRes and BioBrace.
All right, great. So as people know, the Journal of Orthopedic Experience Innovation takes a wide range of articles from surgeon experience to direct from industry to innovators to surgeons who had 50 years experience with anything. Sean, tell me a little bit about the why you looked for something like BioBrace, which is so important to understand the why. Yeah.
No, man. So I guess I'll go backwards. So I did medical school in Philadelphia at Philadelphia College of Osteopathic Medicine, PCOM. But before that, I did a biomedical master's program at there as well. And my research at that time was actually on small intestine submucosa, which was one of the earliest sort of xenografts that was being used in arteries and other places. And my sort of project that I did that really, I think, helped me get into medical school was on using it to regenerate ulnar collateral ligaments in rabbits. Not that rabbits were throwing fastballs, but the idea all the way back then in 2001, I wanted to find a way in my own mind to let the body heal and regenerate its native tissue. So you fast forward now, in intervals of decades, got involved with Regeniten, right? Everyone on this call has heard of Regeniten, the former Rotation medical product, where we found a way to allow new tissue to be induced and to grow in the rotator cuff to help strengthen it and reinforce what's there. And one of the sort of hangups I always had with it, even though I use it a ton to this day, is there was no strength that was there. So again, If I was looking to, augment my rotator cuff and have new tissue grow, that was great. But my fear was always getting them to, that 3-month mark when the tissue would heal. And then the BioBrace sort of came along, and the BioBrace sort of melded the best parts of Bio-Induction that we saw with Regeniten, but added this new twist, which was strength. And the strength was really important to me because I had started migrating my massive repairs and my bigger repairs over towards dermal grafting because I wanted that rebarb sort of phenomenon, or that ability to have strength so my sutures wouldn't pull through the tendon. And we know that's where the majority of those big cuffs fail early on. So this really fit a nice niche in my wheelhouse. And now I have a variety in my bag when I go to the operating room, depending on the type of tear, to figure out what I want to use for each individual tear.
So I want to also tell everybody who's on the call, if you have a question, you can do one of two things. You can just speak up, which I have no problems with, or you can chat. You could put it into the chat for everyone, and I will read the question or ask you to come through with the question. All right. So I read through that article a couple of times, of course, as the editor. I have a question for you. People know me as a joint guy, but when I was in private practice, I did about 70 shoulders a year. And most of them were mini opens in the days of mini opens. And, we could thank the late Charlie Rockwood for pioneering that work. But let me ask you a question. What is really the indication to use an augmentation versus not? I mean, is it a decision made on the table, or what do you feel about that?
So it's certainly something that's evolved in my own practice, and the literature is sort of bearing that out now when you see this sort of boon in industry to augment repairs, right? So I think there's a couple things. One is we're all keenly aware now of who's a poor surgical candidate. A lot of stuff published on that. Smokers, diabetics, revisions, those are all sort of nightmares. And those certainly fall into the category of like, all right, well, we got to do something besides the norm because they're probably going to fail. And then when you start looking at some of the literature that's there, I think there's risk stratification that we can't ignore. And some of this goes back to the early 2000s. You look at Alan Barber's work. Alan Barber talked about dermal graft augmentation back in 2008, looking at rotator cuff failures versus successes in augmented and non-augmented groups. And what they found was, based upon MRI arthrogram, you had almost a 60 or 70% failure rate in the non-augmented group compared to the opposite in the augmented group. So that's a really big sort of striking sort of number that's there, that you can have a huge failure rate without augmenting these larger tears. And I think part of it, Ira, is quite honestly, we've gotten better with our instrumentation, right? I think if everything was easy, we would always do it. The challenge has always been, how do you take something that's going to add additional time to a surgery, but may have a benefit for a patient, and make it user friendly? And I think that's what we're finding as surgeons, and I think industry is figuring that out pretty quick. How do we take something and make it easy to use, to allow every surgeon the opportunity to follow their gut and the literature, which is to augment these bigger repairs?
It's fascinating. And again, if people have questions, just chime in or go through the chat. What other augmentations are out there that you have used in the past that you've had some experience with? And curious if any of the other listeners have had some experience with various augmentations, because I know a lot of companies are getting into the biologic space in sports medicine.
In the last probably 6-7 years, Ira, you've probably seen the boom of these augments. So I'll take you right through my bag right now. In my bag, I'm using dermal grafting, but I'm using something very similar to, well, not similar, something very simple rather, like Dermis on Demand. I think those dermal strips that are out there by J&J, they're fantastic. They act like a rebarb. They also add some bulk to the rotator cuff, and it's sort of, I don't want to say simplified, or really it's simplified the ability to add dermal tissue to a rotator cuff repair without making it hard. So I love that. And I'll use that in the right patient. But in my patients that have, say, partial thickness tears, I like to use bio-inductive implants like the Regeniten. I think those have a really nice fit in my hands for partial tears, but not necessarily full tears at this point. And then, the BioBrace is sort of meets all those factors for me. So if I have someone that's a revision case right now and I'm able to use the BioBrace where I get bio-induction and strength, I'm using on all my big cuff tears. And, Jay Kwan had an article in 2019, AJSM, which was really slick. It's just very much a calculator application. But what they did was they broke down in their article risk factors for failure, and they assigned a point score. So big tears, tears that are retracted, tears that have atrophy, those get certain score numbers. And then other patient intrinsic factors like diabetes, smoker, age, bone density, all get scores. So what you can do is before you even get to the operating room, just by looking at your preoperative assessment and looking at their images on their MRI, you can calculate their score. A score less than 4 basically said that you had about a 6% failure rate. So in that case, I think you can, dealer's choice, do what you want, augment or not augment. I think you're going to get a good outcome. But when you start getting scores of 5 or greater, you're going to see somewhere about a 58% failure rate they had. And if you had a score of 10 or greater, it was almost an 82% failure rate. So those are ones where I'm thinking I got to do something significant here. And then I'm using the BioBrace because it gives me a big sort of sheet that can cover
Right.
that rotator cuff tissue.
So, I always kid around and say, the greatest trick the devil ever pulled is convince the world he didn't exist. And I say that about insurance companies all the time. But I also kid around with my sports medicine surgeons in my department. The greatest trick the shoulder surgeon ever convinced us is that rotator cuff tears never fail, and so in your experience, before you got involved with any augmentation, in your practice, in your hands, and I'd be curious if any other people felt the same, what do you think your failure rate of the rotator cuff tear? Because, when you look on the MRI, it's not good tissue. It's atrophied sometimes. Even with small tears, you get atrophy of the muscle, atrophy of the tendon. So what do you think in your hands, if you did 100 cuffs a year before any of this augmentation, how many would fail to the point where you have to do something?
So I think your last sentence there was the most important, which is fail where you have to do something. I've hit that sort of magic number this past year, Ira, 11 years out. So now I'm lucky enough or unlucky enough to see those rotator cuffs I did 10 years ago or 8 years ago coming back now for shoulder pain. And
Right.
the first inclination is, do you want to image them or not? Because we all know that on imaging, a lot of those cuffs have failed, but subclinically, are they doing okay? So I think that's a legitimate question is, how many of them failed or didn't fail? I can tell you revision wise, there's always a handful that you revise, of your own, admittedly, a year. I'm not going to say it's more than 10%. It's somewhere, again, if they come back to me, yeah, it's a number, let's say somewhere between 5 and 10 a year, you have to get revised, right?
Right.
But those are the ones that come back to you. God knows if they go down the street. But I think there's far more that are doing well that probably have torn for the first time they flex their arm, and they're doing well. And why is that? Well, I think part of it is how much does it fail? Is it a full failure? Is it a partial failure? Is there still tissue that's cushioning the acromion from the humeral head? All those things sort of play in there, I think.
It's fascinating. So there was a question that came up from Dennis D. Bernardis. Dennis, do you want to unmute and ask it yourself, or do you want me to ask it for you?
Yeah, sure. I don't mind. I just, I've seen the Regeniten patch in use. There's other things like the Arthrex cuff mend, and there's the BioBrace. I was curious on your thoughts on the differences in techniques. If you find one is easier, one is quicker, one's less cumbersome. I'm just curious your thoughts as someone who's used it very often.
Yeah, I mean, I don't think there's any denying, and thanks for the question, Dr. DeVinaris. I don't think there's any denying that the Regeniten implant system, the delivery system, is above its peers. I mean, there's just no way around it. It was really well engineered by Tom Westling and his crew to be able to deliver it reproducibly every time and secure it. So in my hands and in many other hands, it adds just a few minutes to the case. But again, that's a great option in my hands for an augmentation of a partial tear. When you start talking about these full tears, I think you need to do a little more, Dennis. I think you do need to you think about doing some sort of dermal graft or biocomposite grafting like the BioBrace, and those are a little more difficult. And I can tell you just some tips and pearls we've learned over the course of time is using instruments that are very simple, like a back grasper, to help insert the BioBrace or your dermal graft through the lateral portal. It makes life a lot easier because it'll slide right in and deliver it where you need it to be. And that's used on many SCR techniques as well. Appropriate suture management to parachute the tissue, the tissue or the graft in as well, again, makes it a lot easier. But I think you got to follow your key principles of any rotator cuff, which is space, visualization, and time management. So I can tell you, I like to do a decompression, particularly if I'm going to graft, to add some more space. I don't want to overstuff my subacromial space. I try to run my pump pressure low as much as I can, and I'm a lateral decubitus surgeon, but I've added in tricks like TXA on all my scopes and epi in the bag, so that way I don't have a big swollen shoulder when it comes time to put that implant in. I think those are little things that if you follow those principles, all your cuffs will be a lot easier to do. But it's the time management and then the tissue management, which really are the challenge, but they're getting better. And I can tell you, sliding in a BioBrace over top of tapes or suture is pretty easy, and it's strong. So I'm not worried about ripping it through the implant like I would say a Regeniten.
It's a great answer. I think that many products allow you to do certain things based on their structure and their technology. Okay. So the question I really have right now is, if I was a patient and I had a 1 centimeter or 2 centimeter cuff tear, 2 centimeter cuff tear, let's take it. Why would you not augment everybody?
Yeah.
I mean, why? I mean, I know maybe you could repair it nicely and the tissue looks good, but you don't have microscopic eyes. You're looking at the outside of the tissue, right? So the question I have is, why wouldn't, and this is a nightmare for a chairman because I'm now spending more money on grafts, but I'm just saying, tell me a reason. If I said to you, why don't you just augment every 2 centimeter tear?
Yeah, you kind of touched on it yourself. I think it's a little multifactorial, Ira. One is we all have to answer to someone. So if I'm adding, X number of dollars to every case, someone's going to come knocking on my door and say, "What are you doing?" And that someone might even be the insurance company who denies it and says, "We're not reimbursing you, for this." So that's one answer. The other part of it is, truthfully, as surgeons, sometimes we get lazy, and that's not a real, great answer, but it's the truth. You get a small tear, you're like, man, I can throw, X number of anchors in and sutures, be done with this in X amount of time and on to my next case. Do I really need to spend the extra 15 or 20 minutes doing something, right? So it's an honest answer, as much as we don't like to admit it. It's human.
Yeah.
But I'll tell you, there's also that gut. Sometimes you look at an MRI, you don't see much atrophy, but you're in there preparing the rotator cuff, you're using your biter to get the fresh edges, and you see that tissue just flaking away. Something just doesn't seem right.
Yeah.
That's one of those cases where even though the cuff might be nice and thick, if I get a bad feeling, I'm going to augment it, and I'll document why. And I mentioned the Jay Kwan article earlier. I'll actually put in my op note why I augmented my tissue. I document insufficient tissue quality. I'll document the score that they had based upon their risk factors. And that's been really helpful with us when I work for a hospital, but when the coders go out and try and get the revenue back from the insurance companies, that's all there for them. It's basically, I've written my appeal note at the time of the op note. And I think that's something I learned from my peers, and it's really helped.
It's a great lesson. I remember when I was a resident, there was a guy in sports medicine, maybe people don't know his name, Dr. Stedman, and he was active at the time, and he gave a lecture to a bunch of us at a conference and said, do what you document what you do. In fact, he claimed that at his clinic, that was up on the wall. Do what you document what you do. And it's true. So, but you're an experienced surgeon in this. Now, let's take Dr. Ford, who in 3 years is going to be working for Bronx Care Health System. as the new chief of sports medicine, I know my chief of sports medicine is on the call right now, Dr. Allen. It's not that she's retired. She's going to be the chairman by then. So what is your advice to the less experienced? You know, you're going by the feel, and I get that. I've done so many knees in my life. I will say, you know, this person needs an augment, this person needs a release, this person needs a popliteus release. But when dealing with the rotator cuff, you're biting at the tissue. Let's talk about the less experienced surgeon, a surgeon who's out 3 years. What are the criteria or the hints that lets you think about an augment?
Yeah, so I teach this to my residents, and a couple of them are on the call, and it's exactly as we laid out before, Ira. You know your patient before you get there, right? So you have to look at your images before. We've all done this. How many times you walk into the room and the MRI is not up, right? But it's important. You need to look at that fatty atrophy. You need to look at the tissue quality, how retracted it is. So that's option A. Okay. So I do that ahead, and many of you all do it ahead of time. You tell your rep, hey, listen, I'm going to need X graft ready to go, right? Just have it in the room ready to go. So no one's running around in the middle of the case to try and find it. So you need to know ahead of time. But then B, you have to look at that tissue quality, like I mentioned. So when, oftentimes I'm preparing and biting the tissue, I might let the resident do the decompression, but I'm the one that wants to feel that tissue. I want to tug on it. I got to figure out, am I doing interval slides? Am I doing releases? And that tells me, as I start to move that tissue and mobilize it, what I'm thinking. Is it, yellow and discolored when I bite it? Is it thin and flaking away? That's going to sort of guide you. And the truth is, as you mentioned, Ira, especially for the surgeons that are a couple of years out, when in doubt, there's nothing wrong with augmenting it. Like you're much better off augmenting it and trusting your gut that you put an extra seatbelt on than you didn't do it and you have a failure, because we're all judged in our first couple of years on our outcomes. And if someone in town sees that Dr. Smith has X number of failures, that's going to be something that gets around, right? The key is being able to put it in effectively. And that's where I think a lot of these labs come in. I think these arthroscopy technique papers that we published and others have published are important. And these panels, just picking brains for ideas.
We always say in the Bronx, the street talks, the street talks. If you have failures, you have decision errors in the operating room, everybody knows about it. So, but it's interesting you mentioned, so let's talk about the technique again a bit, okay? Let's focus on the technique. Would you say on a scale of 1 to 5, 5 being quite challenging to put an augmentation like a Bio-Brace, and 1 being quite easy, where does it stand? Because let's say we have 36 people on the call tonight, and minus you and I, 34. So people are going to say, yeah, this guy's really done a ton of them. I get it. But when you do your first 4 or 5, what's the technique like? What are the specifics of why it adds all that time and everything?
Yeah, so you're right, Ira. What's the truth behind the myth, right? And I think that it's something, and we wrote a technique paper on this in part because we had our own learning curves. We were figuring this out on our own, many of us surgeons early on. It's very similar to doing dermal grafting, and if you haven't done that, I'll sort of take you through the same principle, which is, I mentioned earlier, you need space, you need visualization, and then really understanding the properties of the Bio-Brace is really important because it slides super well and it has a lot of strength. So you're able to sort of manipulate it and slide it down tapes and sutures. So what I prefer to do, Ira, is, I think about this as rebarb, all right, as well as healing potential. So once I get if I'm going to do a double rope, for instance, once I get my medial anchors into that medial tuberosity, I'll pass my tapes or my sutures up through the native rotator cuff tissue. And then I'll actually bring everything out lateral through my lateral cannula. I'll use a passport, a 12 millimeter or 10 millimeter. And then I'll individually pass those limbs of tape or those sutures through the medial border of the Bio-Brace. And I'll mark it so that way I know where I'm at.
Right.
And then using that back grasper, which really changed life for us, to be honest with you, you can shuttle it right down in over top of that rotator cuff. Now you've got not just your normal cuff tissue, you've got an extra 3 millimeters of very strong sort of implant that's there to prevent that tissue from ripping through that maybe crummy rotator cuff tissue. So the sutures now have a double layer of fixation, and then I'll bring them out lateral and put them into whatever I want out lateral for anchor fixation. You can do it any number of ways, and that's actually one of the things that we've learned. At first, we used to lament, oh, there's no delivery system at this moment, right? Well, then we realized that the beauty of that is I'm free. I can put this in however I want, sideways. I can put it in a double row, single row. So there really is a lot of advantages. And the key principle, again, is understanding that it's going to slide over your sutures really well is important. And then like any other surgery, forget the implant, have your visualization ready to roll, and you'll be able to see and put it down without much effort.
All right, so we're at about 30 minutes right now, and I'd like to give the mic to Kevin Rocco, who's the president, CEO, and I think founder of BioBrace and BioRes. Kevin, you want to say a couple of words, and then I'm going to play a little video of the technique and the animation?
Yeah, sure. Hi, everyone. My name is Kevin Rocco, and I'm the founder and CEO of BioRes. I'd like to thank you all for calling in this evening and for your interest in this paper and in our BioBrace technology. I'd also like to thank Ira for pulling this all together, the beautiful music that we all heard at the beginning, and certainly the opportunity to sponsor this journal club. Drs. McMcmillan and Ford, congratulations on this publication. I think the number of views on this paper and the people calling in tonight are a real indication that augmentation is a hot topic in sports medicine today. And we hope at BioRes that the BioBrace will deliver on this interest in augmentation and also this potential to improve clinical outcomes. For folks that don't know much about the company, I'd just like to share that we started as a tiny little startup 5.5 years ago. And our goal was then, and really remains today, to improve tendon and ligament healing. And our hypothesis was that we could do that by developing a soft tissue scaffold, really an implant, that could both load share at time zero mechanically, while also acting as a biologic scaffold to regenerate new tissue. And we've got a really great team behind this technology. It took a long development process that culminated in April of last year with the successful FDA clearance. We got this cleared in a couple of different shapes and sizes. So while we're talking about the rotator cuff here, I'm happy to report that the BioBrace has been used in a few hundred procedures to date, not only in the rotator cuff, but also the ACL, MCL, quad tendon repair, Achilles, Tommy John, subscap augmentation during total shoulder replacement, and about a dozen other procedures. And maybe most importantly, not just about getting these implants in, we're really encouraged by the early post-operative clinical findings. And as a company, we've been committed to producing the evidence. We've really been evidence-based since day one. We're mostly engineers by training. And so we intend to prove this technology out using clinical studies beginning this year. If this is something that is of interest to you, please reach out. Please reach out to us. And look, it's clear to me that in the market today, there's just a huge number of augmentation options. But we really think that the BioBrace is the one that provides this load sharing capability with really a best-in-class regenerative capability. And we think that that's unique. So if you are interested in learning more about the company or our BioBrace technology, please shoot me a direct message here on the Zoom, or you're welcome to email me directly at krocco@biores.com. So listen, thank you so much for your time and your interest this evening. And I'll turn it over back to Ira, Dr. McMcmillan, and Dr. Ford. Thank you.
Thank you very much. I'm going to there's a couple of questions out there, but I'm first going to share the screen of a little animation, which I think is very nice. Hold on a second. I am going to X out of this. Sorry. Let me just find this again. My apologies. I'm just sort of new at computers, so everyone has to be nice to me. All right, here we go. Okay, so I'm going to share the screen of this animation of how to put this in. And here we go. Vigorously fine.
Bio-Res has pioneered the BioBrace. The BioBrace is a bio-inductive soft tissue scaffold with strength, designed to reinforce surgical repairs, promote healing, and fully resorb. In rotator cuff repair, the BioBrace is easily implanted using existing arthroscopic techniques. Preclinical testing has demonstrated that the BioBrace induces a rapid cellular infiltration, leading to the regeneration of new, thicker tendon tissue and a surgical repair that is as strong as native tendon by 12 weeks. The BioBrace implant represents an innovative approach that is designed to potentially shorten recovery and increase the durability of clinical outcomes following rotator cuff and other soft tissue repairs. BioBrace, providing confidence in healing.
All right, so that was good. I am going to put Dr. Elizabeth Ford on the spot. Dr. Ford, you're a PGY2. You think you could do this operation?
I could do it with some guidance from a great skilled attending. Absolutely. I can follow directions.
Right, you can follow directions. Okay, good deal. Good deal. All right. So we have a question from Philip Sussman. Philip, you want to ask the question yourself or should I ask it for you?
Yeah, I was just I just want to ask about reimbursement purposes. Is there any disadvantages or advantages of using a synthetic graft versus a biologic dermal allograft for augmentation?
Yeah, so I mean, obviously the dermal code is 17999. You can get some reimbursement back for using a dermal graft. There actually is a C code that you can use also for a biosynthetic implant. I'm blanking. I want to say it's 167. Kevin, you know the number off the top of your head? It's C1673, I believe. We can get that for you. I just don't have it in front of me. I apologize.
16763.
I think I typed that wrong. We'll actually pull it up for you and we'll get it back to you. But it is worth noting that the BioBrace implant, it's registered with the FDA as an implant, so it can be billed as an implant.
Yeah, okay. It's very important. I'll answer a question as a chairman and a former head of the OR products committee, that in outpatient surgery, you can bill for implants very frequently with APGs with the right code. But a lot of it also depends on the contracts you have with individual payers. I hope that answers your question, Philip, does it?
Yeah. Thank you.
That's good. So I'm going to put you on the spot a little bit, Sean, and say that I always felt that rotator cuff disease or shoulder disease is actually the cause of which is almost completely viral in nature. And I'll tell you why I think it's viral, because it's a virus carried by a shoulder fellowship trained surgeon who goes into a town, and then all of a sudden you see the number of shoulder cases go up exponentially like Ebola virus. So
laugh out loud funny, Ira. Jan Koenig here on Long Island. I just want to give a shout out to Sean and all the sports guys. I'm a joint guy like Ira, and about 10 years ago I had a 30-millimeter tear in my shoulder, and my sports partner fixed it arthroscopically. I was back operating in 4 weeks, back to golf in 3 months, and won the club championship 2-man team the next season. So thank God for you guys. I had very little downtime, and I've done quite a few joints since that time, last 10 years too. Thanks.
That's awesome.
That's awesome, yeah. So let's get back to where do you think the future is going with this? What does BioBrace 2 look like? Like, if you had to improve the technology that's out there now, as a surgeon, what would you like to see in rotator cuff repair?
Yeah, so I mean, look, what's missing, right? So the one thing that we're still looking to see is, how does this work? When I say this, I mean, how would BioBrace or any other future product work if you had a defect you couldn't span? So what do we do now if we have irreparable cuffs? A lot of times we do SCRs, right? If you ask Buddy Savoy, he'll tell you there's no such thing as an irreparable cuff. But in my hands, there are still some, right? So how would this work if you had to, say, span or attach this to a rotator cuff that just couldn't get past the glenoid much farther than a couple millimeters, right? Would it be able to, induce almost like the bearing straight, new tissue to come over down to the humeral head? I mean, that's what we're going to find out at some point. Someone's going to have a case one day where they do that because they have nothing else to do. And I think at least this gives you a chance to, fight that fight. Whether or not it'll work or not, time will tell. But I think the ability to have strength with induction to hold on to what's there is certainly nice. And look, fibroblasts are really, really active. That tissue wants to grow. It's what it's been born to do, is grow. So if you give it a conducive environment to move in a path, I mean, this goes back to my master's 20 years ago, the program I was part of. You induce tissue to grow in the natural path of fibers, right? So think about, Wolff's Law, and think about everything else that goes into healing. I think there's a chance that we could see that, but that's down the road. In the short term, I think as you see, potentially instrumentation or other sorts of advents to deliver this even quicker and slicker, I think you're going to watch, the boom go even more. But I don't think you need implants or delivery devices at this point with it per se. But again, those are just different things that, one person is sort of, giving you his perspective on.
Well, biologics just a huge area. Where else have you used it elsewhere besides the shoulder?
Yeah. So if I'm doing, I'll use it in ACLs, and a couple of reasons why. For me, I've had a couple patella tendinopathies, particular in females. If I do a BTB, so I'll fill in my defect site, my harvest site with this, and I've got a couple of second local ultrasounds and MRIs on some of these gals. That it looks really nice. So that's certainly, I think, cut down a little bit of my patella tendinopathies, particularly in the longer, lankier individuals. I'll augment allograft ACLs because I'm still worried about allograft failing. I try to avoid allograft where I can, but this would be a great spot. And I think, truthfully, I already.
What do you do? Do you wrap it around? I mean, you strip it. What's the technique?
So it depends on the graft, actually. So if I'm using a BTB, I'll actually place it on the back side of the tendon, okay? And I'll use it there, and I think that's going to help me get a little better incorporation to the bone quicker. If I'm using a soft tissue graft like a quad or a tibia or a hamstring, I'll double it over. And I think, again, that's just one more way of adding fixation. We've learned that, we all know this, that hybrid hamstring grafts fail at a higher rate than anything. So, gone are the days where I used to do that when I first came out and I did all hamstring surgeries. But I think those are great spots. And again, Kevin mentioned earlier, I've done a couple of revision total shoulders. I'll do a fair number of total shoulders and subscap repairs. I've gone back and used that to augment my subscap repair when that tissue quality is pretty poor. So I think that's another slick home run area.
What about in Achilles tendon? Have you used it there yet?
So I've used it once in the Achilles, but I know my foot and ankle partners have used it a little more, and they've had good success about that. And Ira, just for clarification for those that aren't familiar with the BioBrace, it comes in either a 23 by 30 millimeter sheet, okay, that we see in the rotator cuff a lot and in the subscap, but also it comes in a 5 by 250 millimeter thin sheet, almost like a hamstring tendon. So that's a great place to augment your ACLs and augment your, Achilles or whatever it might be. Very much like you do a brostrum or something along those lines as well, where you want to go ahead and restore some anatomy.
Not that myself or Jan Koenig ever cut the MCL, but would a joint replacement surgeon possibly use it to augment MCL repair in the case where it gets cut? Yeah.
So I think that's fair. We actually published another article in Journal of Arthroscopy Techniques for MCL repair or an augmentation. Actually, Dr. Arciero and myself were part of that paper as well with his team. And I think that's a fair place to look at it. The MCL, again, extra-articular, loves to heal. So having that brace in there to add some biologic activity, I think is a good place to put it. Knock on wood, haven't cut an MCL yet from the time of the BioBrace, but I think it's a good option.
Yeah, well, you're going to cut one tomorrow because you just said that. But,
I'm not going to do any more total knees ever again, Ira. That's what that means.
It's okay. It's okay. We'll leave it up to Dr. Ford to do most of those. And, you know. So we got that. So have you gotten any pushback from administration on cost?
So we actually presented it.
Not that there's such a thing called administration, but yeah.
Yeah. No, so look, we compared it to what we were doing, right, with Regeniten and dermal grafting at that point. And to be truthful, it fits right in with that price line of where everything sort of is. So it's not like it's actually it's cheaper in some cases in my hands than that. But I'll give you another example. So I have a partner who does a lot of hamstring ACLs in the area. I say partner, another surgeon in my area. So he only uses one strand sometimes of the hamstring, and then a BioBrace. He's taken his MPFL reconstructions, and instead of using a hamstring allograft, he's just putting a BioBrace in, and he's saving on costs that way, he believes, and certainly adding a biologic element, particularly in those kids that we've all had a parent look at us and say, "You're going to put dead tissue in my 15-year-old's knee for an MPFL." So I think that meets a couple different needs there. So knock on wood, we haven't had a ton of pushback, but again, like everything else, if we start going like cowboys without justification, you're always asking for a knock on the door.
All right, we have Jacob Triplett. Jake, would you like to ask the question yourself, or you like me to go for it?
No, yeah, I'm more than happy to ask the questions. In the article, it discusses that the the BioBrace provides strength up to 24 months, and essentially that it's not a permanent implant. I was just wondering, can you comment to this? What happens after time zero of when the BioBrace is implanted? How does the degradation process occur, and what happens from 0 to 24 months?
Yeah, so it's a great question. So one of the things I actually like about the BioBrace and the Regeniten is it goes away over time. So whereas dermal graft is going to be there forever, the BioBrace, in this case, it induces new tissue to grow to fill in that gap. The strength degrades over 2 years, and there is an algorithm. And Jeff Ott, if you're on this call, you can probably speak to that a little bit better as far as the degradation goes. But even after it degrades at 2 years and loses some of its strength, it still is there and resolves at a slower rate after that. So I don't want to give you a misinformation here. Jeff, can you speak to that really quick?
Oh, I think.
Hey, can you hear me?
Yeah, I can hear you now, Jeff.
Hey, you guys can hear me, right?
Yeah. So Jeff, can you just speak to the degradation in the first 24 months? How the BioBrace?
Yeah, sure. So the BioBrace has strength out for 2 years, and it has strength. It starts losing that strength probably 2 months into that, and then linearly loses strength out through 2 years, and then it fully absorbs after that.
That's great.
So and just to follow up, Jacob, you asked about the wicking. I'll just touch on that for you for a second. So I soak my BioBrace primarily just whole blood. So when I'm getting ready to reconstitute it, I'll put it in my little basin in the back table, and I'll just get 5 or 10 cc's of blood from the anesthesiologist, and I'll just soak it in whole blood. I have a colleague of mine, Dr. Rusinella, who soaks his in PRP. I'm sure I'll get anything else. You can soak it in BMAC. But what's interesting is when I put the BioBrace into the shoulder, just with the whole blood, I have plenty of pictures that I could share where the BioBrace actually holds on to the blood. So the whole time you still got fluid running inside that shoulder, you still see the BioBrace, red, crimson. So it's retaining what it's reconstituted with, which I think is important because that just adds an extra biologic factor. I just, not for any good reason, haven't done the PRP simply because we don't have a centrifuge readily available in my OR all the time.
Interesting. It's interesting stuff. So getting back to sort of the technique, have you had any pullouts, or how does it grab the suture? How does the suture grab the tissue in comparison to a rotator cuff? Does it pull through? I mean, what's the feel of it?
Yeah, so let's talk trial and error, right? We all learn by mistakes. It's strong. My kids call it the napkin because they played with it a couple times when we were doing some early testing. But it's got a really strong sort of feel to it. You can actually pull it, and I wouldn't recommend doing it on a real one, but you can practice with it when you get it in your hands, and it's not going to rip. That said, when I pass my sutures on the medial side, I try to go about 3 to 5 millimeters in from the edge of the implant. So that way there's less chance of it ripping through in the case of something going wrong. I've learned from passing, there's all different ways to pass sutures through. The Scorpion, I typically use a Scorpion in my OR. It can be a little aggressive. The blade could be a little aggressive on the BioBrace, but it's fine. I find the Espresso is a little easier to pass it with. Same thing, the Cobra, the Striker Cobra has been a little aggressive. You can do it, but you got to be a little slow when you pass it. A lot of times I'll just simply use a free needle to pass it through, or I'll use a spinal needle and a Chia just to pass it through as well. But once you're through it, if you're far enough in from those edges, a good 3 or 5 millimeters, it's not going anywhere. It's going to stay, and it's going to stay nice, Ira.
Very interesting. Do you ever have to cut it to size, or you just put it in whole as is?
So no, I've cut it before. So again, those smaller tears that we talk about.
Yeah.
I've cut it. I've turned it sideways. So a couple of times I've done just a single row repair where I throw, free number 2 suture into my rotator cuff, maybe 5 or 6 strands. I'm just bringing it out lateral into 2 or 3 anchors on a single row level. I'll turn it sideways to get more coverage from A to P, and I'll just throw it in that way. But yeah, I've cut it before if I feel like it's going to be too big and floppy, and it's fine. It doesn't lose its strength by doing that.
Have you changed your rehab protocol since you've been more aggressive with augmentations, or are you still as conservative or as aggressive as you've been before? Have you slowly over time altered that rehab protocol?
So that's an awesome question. I can tell you, I haven't changed my protocol, but I think my patients have changed theirs. I saw a guy today, and that's why it's fresh in my mind. 3 months out, and he comes in, he's all proud of himself. And to be fair, he doesn't necessarily understand that I did this biocomposite grafting that's unique or whatever it is. He just knows I fixed his rotator cuff, and he waving his arm. He feels great, and he's telling me, I feel good, but I'm trying to listen, trying to do too much. I think I've seen early on a little less pain in some of these patients, and I think part of that is you don't have the sutures pulling on that thin rotator cuff tissue. You've added bulk at time 0, which decreases some of the force across the cuff. So I think that's important. And then 2, I mean, they're healing at a good rate. I've been lucky enough to track a lot of these patients with ultrasounds. We'll take a look and MRIs. So we're seeing that tissue sort of heal nicely. And I know some other colleagues have posted on LinkedIn, et cetera, but that's what we need to do is actually track these things.
Yeah.
Like everything else, Ira, there's good and bad. I've had a patient get stiff at 3 months. And again, we were able to work through it with, I did some injections of Toradol and lidocaine and sort of broke up some of that subacromial space. And we've seen some of that stiffness, again, with other implants like Regeniten. It's more a matter of understanding it, recognizing it, and working through it. Nothing's perfect, but I think this is a really good option.
No, it's great. And it's great stuff. I really like the question from Jacob about soaking it in PRP or blood. It makes sense to me to even augment it further, with something like PRP. But I understand what you're saying about the operating room not really having the centrifuge. It's incredible how many times we make decisions based on practical considerations, versus an ideal scenario. I do like the idea that you're getting the 10 cc's from the anesthesiologist and not from the patient.
Yeah.
Yeah, just kidding. Just draw some blood from my colleagues. Do we have any other questions out there for now? Stem cell augments was a question. Stem cell augments.
Yeah, so, Dr. Koenig, I'm assuming you mean, am I soaking in stem cells? Is that correct?
Correct.
So again, I haven't done that yet. Again, same principle. I don't have the centrifuge around. I have to kind of plan for that one. But I do sometimes marrow vent. So I'm getting sort of poor man's stem cells. I'm getting that to come up through. So again, I use vented anchors. Many of us use vented anchors. But I think between that and doing a little crimson duvet or a little microfracture, I think you're getting some of that bone marrow. Plus, I do a decompression, as I mentioned, a pretty generous decompression when I'm putting a graft in. So I think you're getting some of that biology in that regard.
Wonderful. A lot of future, I see.
Yeah, I think Jan's right. I think this is just an amazing area. Do you think we will see possibly less reverse shoulders with a lot of these augmentations, with these rotator cuff? Can you use it in a rotator cuff arthropathy or anything of that nature?
So I put one in. So let me go backwards. Again, total shoulders. I got in there a couple times, and I put in the past Regenitens and other things over top of a cuff when I'm doing a regular total because that cuff looks really thin. I have done that with a BioBrace as well in an open total shoulder just to put something else over it because I was worried. So again, that's on supraspinatus I'm talking about. I mean, time will tell, Ira, what happens with the reverses. I mean, I think inherently rotator cuffs, even with this, we're still looking for that secret recipe on how we're going to get them to heal and last for 20 and 30 years.
Yeah.
So time will tell on that. But I think to your point, now that we're as shoulder surgeons more aware of the need and the benefits of augmentation, even if it's seeing less subclinical failures, I think that's important. And I think that in and of itself is going to cut down on some of it.
It's great. I mean, if you could get a rotator cuff for the last 30 years, I'll have you put one in me so I could. I'm going to be 65 this year, so that makes me 95 when it fails. And
Dr. Ford can do your reverse then, so that'll be good.
she'll do my reverse then for free.
Yeah,
no charge. It's really good. So we only have about 6 more minutes left. Dr. Ford, what's been your experience in the operating room? Sorry to put you on the spot. What's your feeling of excitement of watching this new technology?
I think what I like most is that it's kind of always changing. Like I've seen some of the previous mentioned, like Dermis on Demand, I've seen the Regeniten, and now the BioBrace. And it's just really cool to see the evolution and, kind of just the thought process behind why someone chooses one thing over the other. I've really enjoyed kind of just experiencing that and soaking in that knowledge from different attendings and of course, Dr. McMcmillan.
That's great. Sean, you have any last minute comments for us on this whole thing, or maybe some comments on the journal?
Yeah. So
self-serving as I am.
Yeah. Listen, I'll give you 2 things, Ira. The first thing is, thanks, because all kidding aside, your journal gives all of us a platform to get information much quicker than what we would through any other journal. Like you say before, it's peer review, it's legit, it's honest. And the forum that you have lets a lot of us read it and give instant feedback. Someone doesn't like an article, they're going to say it. Someone likes an article, they're going to say it. But if you have a question on the article, you can put it in there on the internet and you can get an answer pretty quick. So that's helped certainly me and my residents a lot. On the BioBrace, I mean, again, we're talking about the BioBrace, and I think it's a fantastic option, but it's an option, and there's many other options too. And I think the key for us and those that are like Dr. Ford that are still learning is know exactly what's good in your hands, because that's going to give you the best outcome, but also understand why you're putting something in. So if someone walked up to you and said, hey, Dr. Ford or Dr. whatever, why are you doing this? You're running up costs in my hospital. Know your literature, know why you want to augment, know the success rates, know the outcomes. And I think really the BioBrace, as Kevin Rocco mentioned, they're very, very literature based and collecting data, and they're trying to be thoughtful about this, not just say it works because it works, but what does it look like on MRIs? What does it look like in clinical trials? And I think that's where we all need as surgeons to sort of, collect our data and share it to find out what's really good for our patients.
Yeah, I thank you very much for your comments about the journal. One of the reasons we really started the journal was to see if we can get early results on things and not wait 5 years for someone to tell us something failed, there's a court of public opinion in a sense on LinkedIn and elsewhere. I do want to share in the last minute or two my screen on this article. So we'll see, you see here, this article has gotten 1,142 views and 52 downloads, which is really remarkable, and it's still growing. It's a great journal in that sense. I want to point out to everyone on the call tonight that if you go into this area, CME, this within the next few weeks, we'll have one of the choices will be CME, but it's based on the article. So you'll be able to have at a nominal fee CME. And additionally, we have recordings and podcasts. So all of our journal clubs, including this one, will be a Spotify podcast and will be a YouTube video that will come up. So I want to alert you to the fact that the journal has this area of podcasts and CME based on this remarkable article, which I think is really phenomenal. I want to thank Sean, Dr. Ford, Robert Arciero, who couldn't be with us tonight. The operating room calls. He must be there. And I want to thank everybody on the call who came in tonight. We had about a 85% show rate, which is better than my clinic, Sean. So it works out well. So I want to thank you and Dr. Ford and everybody tonight who joined us. Okay. Thank you.
Thank you for the opportunity. Good night, everyone.
Good night, everybody.